Thank you. I'm going to talk about the implementation of NOL in our clinical practice, because we talked about the room for improvement in postoperative analgesia. We talk about the proper monitor to control our analgesia, but something still doesn't work. Why clinicians are used to monitor hypnosis and curarization? Because we are afraid about consequences for the awareness and for the postoperative residual curarization. What about analgesia? Why we don't measure it? Because if we cannot measure it, we for sure cannot manage it. Is it a problem of technology? Maybe the monitor we can use are not still good as we prefer, or it's a problem of culture. Maybe it's a matter of technology. We can think about the postoperative residual curarization. This is the paper per year that have some linear correlation with the diffusion of train of four watch technology. So the problem arises when the technology is the right one to locate it and to highlight the problem. But it's not so easy. It's not only up to technology innovation. Gutenberg invented the printing in 1448. It was a technological innovation. But before a real revolution, we have to wait for the change of mentality, just several centuries after the innovation. So it's not always up to technology, but we have to be ready and prepared to receive that technology. This is an interesting paper talking about the decision-making in postoperative analgesia. I used to talk about safety, decision-making in patient safety. There are a lot of bias while we are managing our intraoperative analgesia. This is the one most surprising, the overconfidence bias. When we use local anesthetic to perform a block, our patient more probably will receive an underdosage of opioid because we are too confident. And this is an example of how we are not ready for a real revolution, or how we have to change our culture before to understand the nociception, because there is an inverse trend when it's up to nociception. We talk a lot about nociception, but we don't talk enough about how to monitor nociception and how this can help us in clinical routine. Maybe it's a matter of mentality, because one of the limits of introduction and implementation of nociception monitor in our routinary practice is that clinicians want the magic number. This is pain, this is not pain. But you have to understand what is behind the nociception. Otherwise, it will not work for you. And the problem is that medical literature still has to face evidence not so strong, a conflict of interest, small sample size. So the sensation, feeling is, I'm not sure if it does not work or there's something to it, because we talk about nociception. I think that definitely something to it, and I'm going to show you how the NOL monitoring in my routinary clinical practice gave some hint and managed some cases that I find interesting. This is an elective right lower lobectomy in a patient fit for surgery, no relevant problems, but an Ganzuri score of 4 is a score for a difficult airway, but nothing really to be worried about, just a 4. So the resident prepared the operating room. These are the real average hemodynamic pattern of the patient. On the left, this is the baseline. She performed TCI anesthesia with propofol and remifentanil. These are the targets. She administered rocuronium, and then she went for the laryngoscopy. You can see the orotracheal intubation modification in hemodynamic pattern, so nothing really special, just a rise of a heart rate of 20%, blood pressure was stable, and she successfully intubated the second attempt. She reported difficulty routing of the tip of the double lumen tube. It's 41 French, so it's not so easy, but definitely not a problem. And this is our NOL trend, a clear rise in the nociception during the laryngoscopy. Okay, then what happened? We put the patient inside position, and there is an evidence of air leak. The loop is not closed. We check the tracheal cuff that is broken. We have to change the tube on the same patient that felt pain at the first laryngoscopy. She asked for consultant supervision, it's me, a tube exchanger, and a video laryngoscopy. I know that it's not so adequate, the double lumen tube with the airway exchanger, but the real thing is that we raise the Minto target to 6 nanograms per milliliter, because at the previous intubation we had pain. So just give a look to the lung procedure, laryngoscopy, then the suction of secretion, then we remove the lumen tube. There is the tube exchanger in the left main bronchus, and once again, there are some problem with the routing of the tube, because probably is not the right management of this case. We change the hand, so a lot of time I try to rotate. At the end, I remove and use a different stylet to perform intubation. And this is the hemodynamic pattern. Okay, I rise with the Minto, with no hemodynamic, no hypotension, no modification in heart rate, and NOL was perfect, just rising 1 point. This was very interesting because it's difficult to make 2 laryngoscopy in the same patient. And if we talk about scientific evidence, a lot of targets for the TCI remifentanil are calculated with the up and down technique. So every triangle is a patient. If he feels pain, we try a higher dose. Otherwise, we go down. And so we describe these graphics with an AC95, an effective remifentanil dose to cover the laryngoscopy in 95% of patients, very high. In the double lumen tube is 9.9. Have you ever intubated a patient with a 9.9 remifentanil in TCI? So the risk of overtreat the patient with opioid is very high if we think in this way. Moreover, the studies about pain during laryngoscopy rely on hypertension and tachycardia that may be a reflex for epipharynx stimulation. So why don't we start to monitor in this way our laryngoscopy and our nociception during this maneuver? We can understand a lot of things, or try to define in another way the right target for the procedure. Same patient, side position, this time no air leak. We perform thoracic paravertebral block. Patient has not a so brilliant ultrasound anatomy, so on the dark blue, I perform a classical paravertebral block. On the light blue, we have to inject local anesthetic just above the costotransverse superior ligament. It's an approach less effective. Then we go for surgery. A surgeon put the trocar, okay, in different area that we are used to cover with the paravertebral analgesia, and on the lower medial trocar always have rise in during the scoping. Maybe there is pain in that area. This is the same patient. We used to inject methylene blue while performing the block to check the spread of the local anesthetic to prevent the uncovered area of analgesia. And the surgeon confirmed us that the spread of local anesthetic is stopped at the 6th interparavertebral space. Not enough. I'm lucky to rely on the methylene blue direct vision. Otherwise, I could rely on the NOL. The lower part of my analgesic plan is failed. And this is important because when we face severe postoperative pain, we don't know what there is inside our locoregional analgesia before the end of the surgery. We can imagine, we can think about, we can be worried, but there is a failure rate that is always present, even in ultrasound-guided procedure. And if I can anticipate and switch from A plan to B plan, I think it's better than run after the pain of our patient. There is evidence of topping the locoregional analgesia technique and improvement on the NOL pattern of the patient. Same thing in epidural analgesia. This was a particular case with the difficulty anamnesis due to cultural gap of the patient, no mediation, no sedation. The epidural positioning was more similar to a wrestling match than an anesthesiology procedure. I was not very sure of the right positioning of the epidural catheter. And this is in the light blue, the bolus of epidural, and you can see the NOL overview during the radical mastectomy, even at higher metamia. Everything was good, but what about if I learn about my technique failure after surgery? Mastectomy, chronic pain, a huge surgical field. I could think about playing plan B and C plan even. This is the patient, and the NOL confirmed the proper analgesic coverage, and this is the same paper shown cited. It can be useful to give you a feedback on a technique before it's too late. And this is the last case that gives some light on something we are not used to think about. Surgery patient from ICU or patient in critical condition. We are always worried about the comorbidities, and we underdose the opioids because we are afraid of hypotension or impact of hemodynamics. This is a patient with acute respiratory failure in COPD. She underwent tracheal intubation, then switched to tracheostomy. She had septic shock and a tracheoesophageal fistula that needed to be repaired because it was wider than 3 centimeters. This is our patient. The first NOL rise is at the tube manipulation and the first bronchoscopic inspection, nothing special. Then this is the phase in which you remove the tracheostomy tube and you put the cross-field tube with the tube exchanger inside the surgical field. We have a severe desaturation, then the incision, but the hemodynamics didn't reveal us a high perception of pain if NOL didn't rise the index. So this is a practical example of how NOL changed our strategy during surgery. In the face of prosthesis positioning, patient experienced pain, nociception at the NOL, but give a look to the hemodynamics. Who could think that this patient was feeling pain, had a severe nociception, because it's hypotension cover any other possibility. And considering the hemodynamic status, we switched to ketamine analgesia intraoperative with a good response at the first of the post-administration time, but it was a difficulty patient to keep the proper analgesia. But at least we switched to another plan. We tried to change our approach. We don't just rely on the multi-parameter monitor, because this is a black hole of information about the pain in intensive care unit. This is an old paper 20 years ago, but there is no a lot of data about this issue because nobody wants to show his dirty clothes. But patients are always at risk of underdosage of opioids after surgery once in intensive care unit. And this is a problem very sensitive, especially in patients in coma that cannot communicate with us. In fact, we should think that the proper analgesia can help us in a lot of ways for an ICU patient, for the fighting of ventilator, for the delirium, the agitation, physiotherapy, hypoxia, all things that we never consider can be related to the pain after surgery. In fact, there are the first sign of attention to this topic, because you cannot rely on vital sign during stay in ICU. You have to use technology measuring heart rate variability or different physiologic parameters to be sure your patient has not experienced nociception. So I give you my take-home message. Before turning on the monitor, you have to light up the knowledge about nociception, because if you are only looking for the magic number, you will not find it in the monitor. So spend the same time to get the best antinociception as the best ventilation. We are used to change our ventilator strategy during surgery. We try several parameters, several strategy, pressure, volume, respiratory rate, relying on the oxygen level. And it's not easy, but if it does not challenge you, it won't change you. Thank you.